Yeah, so I am extremely privileged to introduce the next speaker, Dr. Hari, who is quite well known to the AKMG community. For those who do not know him yet, so he graduated in Toronto Medical College, and he joined. He started his fellowship and residency in UK, and then moved to Medical College of Wisconsin for his hemato-oncology fellowship. He is currently the professor in Medical College of Wisconsin, Milwaukee. His area of interest are research in stem cell transplant and multiple myeloma. And his recent researches include the convalescent plasma therapy in COVID-19. So I would welcome Dr. Hari to give us a talk on thoughts on COVID-19 immunity and aging. Welcome, Dr. Hari.
Since AKMG has a lot of members who are above the age of 45 or 50, we are talking about aging in a sense. One might wonder why I'm talking about COVID too as a hematologist and an oncologist. Mainly because I work with viruses. My research essentially is in cellular therapies, and we actually use artificial viruses to transfer genes into various types of cells and do gene therapy. And that has been what I've been doing for many number of years now. So I know a little bit about viruses and a little bit about immunity, being a bone marrow transplanter and an immunotherapist in cancer. So, but again, it's easy to talk about COVID-19 because nobody knows the definitive answers to anything in COVID-19. So that's why I labeled it thoughts, because these are just thoughts. So we'll do a quick primer on the immune system and viruses. And this is something that everybody on this in this audience should know. Essentially, COVID-19 is caused by a virus known as SARS-CoV-2. And it is an RNA virus, and it has single-stranded RNA, just like in that picture here. And it binds to a receptor on the surface of cells. This receptor is known as ACE2, and it is expressed on a large number of cells in the body, including, most importantly, nasal cells, lung epithelium, and also some cells in the myocardium, kidney, etc. And after binding, the virus and a bit of the receptor is broken and it gets into the cell, and the virus by definition has to get into the cell nucleus to replicate. Once it replicates in the nucleus, more viral protein is produced, more viral nucleic acid is produced, and then the cell bursts, leading to cell death, and then more virus is shed. So viruses rapidly replicate in the body. Using this process, they hijack the nuclear machinery of the host, and that's how they reproduce themselves. So unless the virus gets into the nucleus, it really cannot reproduce. And unless the virus gets into the cell, you cannot get into the nucleus. So basically, that's one mechanism of treating this virus. The immune system has evolved along with viruses and pathogens. Our immune systems are very, very good, as you all know. We live surrounded by viruses. Every animal, every dog, every cat, everything in your household has its own viruses, and none of those attack us. Most of the time, it's because these viruses do not have receptors to enter our cells. And the second possibility is that our innate immune system, which is the non-specific immune system, which all of us have. And in the context of aging, as I will explain to you later, that becomes even more important as you get older. So the innate immune system takes out viruses even before they get an opportunity to infect too many cells. That's another mechanism. The adaptive immune system is, on the other hand, is the immune system that most of us remember from medical school. This is composed mainly of antibodies, or B cell immunity, or humoral immunity as it used to be called. And the other type of cells that mediate the immunity is called T cells, or cellular immunity, cell-mediated immunity. The classic feature of adaptive immunity is that it has memory. So once you see a virus or a bacteria or any other pathogen, and if you have developed adaptive immunity against it, your body is constantly producing, whenever you see that virus again, your body will produce antibodies or cells, multiplying cells that can take out this danger. And this is called an anamnestic response or a memory response. If you don't have a memory response, it's not an adaptive immune system. And adaptive immune system has evolved again. It's one of the most highly evolved structures in our body. And it undergoes what's known as somatic hypermutation. It is a permissive situation where our system actually permits some mutations to happen within that system both in the B cells and the T cells, so that a sufficiently specific response can be generated against a target that we have never seen before. So when SARS-CoV-2 is a new pathogen to human beings, nobody ever produced antibodies against this pathogen before in the history of humanity. Suddenly this comes in, and we have people walking around with antibodies in their blood because our adaptive immune system has the capability to select out a protein that will kill this virus or inactivate this virus. So that's the beauty of adaptive immune system. So both of these immune systems has to play together for a successful antiviral response. And the first thing that I would like you all to remember is that the discoordination between the two immune systems, the innate and the adaptive immune system, and the delay in the adaptive response is probably what leads to a really bad COVID infection and leads to death in patients. So innate immunity is the first immunity that meets the virus when it gets into our bodies. And that is mediated by specifically one group of proteins, or the most important group of proteins is called interferons, again, which all of you know about. The interferon response basically slows down the virus. And as you can see in the cartoon here, you can actually, virus infected cells release interferons, which basically bind to the uninfected cells, which then are protected against the virus coming in. And the cellular part of the innate immunity is called NK cells, or natural killer cells. These cells are non-specific cells, and they are very effective at neutralizing viruses or virus-infected cells. So when a virus infects a cell, that cell displays sufficient signals to the NK cells to suggest that there is something bad going on here, and the NK cells decide to destroy those cells. And that again happens non-specifically. They don't know it's SARS-CoV-2 virus or influenza virus or what virus it is. They just non-specifically attack that. So that system is under a lot of checks and balances, because if that happened all the time, we would also be suffering a lot of damage to our bodies from these NK cells going rogue. So that's why innate immunity then hands off the rest of the dealing with the virus to what we call adaptive immunity, which basically, as we told you before, leads to the T cell response and the B cell response. And the T cell and B cell response again have to be coordinated with each other. So the T cells can only respond to bits of the whatever pathogen comes in. So it's like a T cell cannot see an apple and say it's an apple. The apple has to be digested, and a protein from the apple has to be expressed on the surface of another cell known as a antigen presenting cell. And if the antigen presenting cell presents that bit of the apple to the T cell, then the T cell says, okay, this is a foreign antigen, I'm going to respond to it. And then the T cells have a response. Again, similar, but with the B cells, it's a little different. The B cells actually make antibodies, and the B cell response also needs a T cell response to help it. So a cooperative T cell and B cell response leads to the production of a successful antibody, which initially is an IgM antibody, and over time undergoes something called a class switch, and then you get an IgG antibody. And antibodies are excellent in that antibodies your first line of defense once an infection has happened, and that antibody can recognize the whole apple by itself. It doesn't need to see a bit of the apple as a T cell does. So our immune system, therefore, is a mechanism of recognizing proteins. And there are a wide landscape of antibodies that are produced. And when a pathogen such as SARS-CoV-2 infects our body, there are many, many antigenic particles in that particular virus. As you can see here, when you say there's a spike protein, that is a spike that penetrates into the cell. The genome of the SARS-CoV-2, the RNA that is associated with protein, that's called nuclear protein, and that's here. And then there is membrane of the virus, that's called a membrane protein. There is an envelope protein or an envelope protein. That protein is a cover for the virus. So many of these proteins can generate antibodies. And a lot of the antibodies are produced because each B cell in our body it undergoes multiplication. And when there is a lock and key mechanism that happens inside our lymph nodes, by which there is a selection of whichever B cell has a receptor that can specifically target these proteins. So when a B cell successfully can engage one of these proteins, then it becomes selected out to multiply, and then it makes antibodies that can fight these specific proteins. But not all of those antibodies are effective. So only some of the antibodies can neutralize the virus. So for example, we know that the most effective antibody that can destroy SARS-CoV-2 is what's called a neutralizing IgG antibody against the spike. And not just against the spike, it's a specific protein at the end of the spike known as the receptor binding domain. So unless an antibody can bind to the receptor binding domain of the spike, that antibody can inactivate the virus. Other antibodies which do not bind to that area cannot neutralize the virus as far as we know. So an antibody assay that we do for the test, a lot of people have had antibody assays. It really depends on what protein you're measuring. So when you say that I have antibodies against SARS-CoV-2, for example, in India, the most common protein that they measure in an antibody assay is the nuclear capsid protein or the N protein. For example, in Dharavi, they said 70% of people have antibodies against N proteins. I really don't know how specific that is and how specifically can we state that all these people have immunity against the nuclear capsid protein. Whereas if you do an IgG against the spike protein, we know that those people do have immunity. So that's one thing to recognize. Second thing, that even if you make antibodies, the response may be insufficient or absent in many cases. I have a lot of people with blood cancers who are on treatment with agents that reduce their immune response, and those people have recovered from COVID, but they don't have an antibody response. So that's another thing to remember. And finally, there is also a possibility that some of these antibodies actually do what we call immune enhancement, and that may be harmful. So these were all thoughts that ran on in our minds when we were designing plasma studies for COVID. So here is how the testing goes these days. The first test is that turns positive is what's called a PCR, as you all know, is a method of detecting nucleic acid in a person's blood or any other tissue. And that specifically looks for little bits of the RNA of the virus. And the PCR can remain positive even after the person recovers, because you don't really need intact virus to be PCR positive. But the PCR is a test that first turns positive. You also can look for antigen test, but the antigen test again needs a specific load of the virus to be produced in your body. And then basically it's a test that uses an antibody to recognize the antigen, very much like a pregnancy test, where you actually detect the HCG protein. Here you're detecting a SARS-CoV-2 protein. Finally, as patients recover or patients have infected, and after about 5 or 6 days, patients start making antibodies. As you can see, the green line shows antibody assays, and they turn positive once the antibodies that's reached a certain level. You can measure antibodies, and they turn positive a little bit later. And the first antibody, as I said, is an IgM, and then the second antibody, the second wave happens, and that is IgG antibodies. So IgG antibodies are long-lived. In SARS-CoV-1, we know that the median half-life of those antibodies was measured in years, but in SARS-CoV-2, it looks like that could be around 4 to 6 months. And that again is a little early to say. So there are a lot of variables in testing that causes a lot of confusion. I don't need you to read the whole slide here, but again, looking for virus is one way, looking for viral antigen is another way, looking for antiviral antibodies is another way. So they're actually looking at the same problem as the blind men who saw the elephant. They are looking at different aspects of the problem. And if you look at only one thing, you are not getting a whole picture. And finally, many people have cross-reactive antibodies that bind against or other SARS-like viruses, such as SARS-CoV-1, for example. So the two most common tests that are done in the US are the Thermo Fisher TaqPath COVID-19 combo test, where it looks for 3 targets. And if all 3 targets are positive, they call the test a fully positive test. If 1 out of 3 is positive, they call it a presumptive positive. That really doesn't mean much. So you have to redo the test again. So redoing the test is a good thing. So basically, if you get a presumptive, you're not in evolution to become positive later. It may be that you have some cross-reactive material in your body. So again, as we said before, innate immune response and adaptive immune response are crucial in our defense against this virus. SARS, MERS, and SARS-CoV-2, these are our 3 new coronaviruses. We call them the novel coronaviruses. All of these viruses have the ability to block the interferon response. We talked about innate immune response and the interferon being the prime protein that drives this response. So the innate immune response gets blocked by this virus. So the virus, in the race between the virus and our immune system, the blocking of interferon gives the virus a head start. It's like a marathon where the virus gets to 5 miles, and our adaptive immune response and our immune response are just getting started at that time. So basically, there's a significant viral load in our bodies by the time the adaptive immune response is getting turned on, or even the innate immune response has actually started killing some viruses. So this leads to what we call a dysregulated adaptive response. And this rapid viral replication and bypassing of intrinsic defenses is better for SARS-CoV-2 than SARS-CoV-1. And that has happened because that is thought to be the result of a mutation in a specific region in the virus's RNA. So, and again, this is the reason why instead of getting your IgG response as a normal, in a normal adaptive response, you actually involve a lot of other cells that are bystanders, such as macrophages, monocytes, and neutrophils, to go into the SARS-CoV-2 infected tissues and then cause more tissue damage. So this pathogenic or dysregulated inflammation, which is on the leftmost part of the slide, is caused by robust virus replication, delayed interferon response, inflammatory monocyte, macrophage, and neutrophil infiltration in the tissues, which then those cells secrete what we call cytokines, which are chemical messengers between white cells, and chemokines, which attract other chemicals and cells. And that leads to endothelial and epithelial apoptosis or death, vascular leakage, suboptimal adaptive response, and impaired virus clearance, which can lead to lung injury, ARDS, death, and a specific syndrome that we nowadays call cytokine release syndrome. If you get the right inflammation or the protective regulated inflammation, early interferon response delays the number of cells that have the virus. You don't need as much monocytes and macrophages and neutrophil infiltration, because a majority of these cells, virus infected cells, have been killed by the NK cells. And then your adaptive immune response comes in and it produces neutralizing antibodies. No more virus can get into other tissues, and you heal up. So this unregulated or dysregulated immune response may underlie the difference between severe COVID and non-severe COVID. We know that young people have responded really better to COVID. This is the mechanism by which people have thought that IL-6 blockade and other immune blockade, actually immune suppressing agents such as dexamethasone, might help, because you don't want a runaway pathogenic dysregulated immune inflammation state in patients. So I was very excited about this drug called tocilizumab, which is an IL-6 blocker. And this is the drug that we use commonly in cancer in patients who got what we call cytokine release syndrome. But that in a randomized study that was just published last week in the New England Journal of Medicine, it did not work. So although we know all these things about the virus, it may not be the whole picture. And that, I think we have to be humble and understand that that is what is, our story is a story at this point, but we are gaining more and more understanding in this. We decided to use this in a clinical trial only because when we measure people who had severe COVID, we find that the IL-6 levels are elevated. CRP, which is the poor man's IL-6 test, is also elevated in patients with severe COVID. And many other chemokines and cytokines are elevated. Tumor necrosis factor alpha, CXCL8, all these are agents that tell us there is active pathogenic dysregulated inflammation going on in the lungs of these patients. So that's why this was tested. There are many other immunosuppressive agents being used. One group of drugs known as BTK inhibitors or Bruton's tyrosine kinase inhibitors that again reduce the B cells from from multiplying rapidly. There is another group of agents called JAK inhibitors, which actually stop the T cells from effector function. So those are all mechanisms that are being pursued right now. But important to realize that tocilizumab, which is an IL-6 receptor antibody, did not work. So here I'm showing you what a coordinated immune response looks like. So patient gets infected before day zero. Day zero is symptom onset. By that time already there is CD4 T cells and CD8 T cells that are actually starting to expand. So the innate immune response has actually slowed down the virus. And by the time of symptom onset, there is a T cell response that's starting. And that then leads to a handoff to B cells, and the B cells become what we call plasmablasts, and then eventually plasma cells that secrete antibodies. And then they persist long-term for the future as memory B cells. So even though the IgG goes down, the memory B cells persist. And if you get the virus again, you can get what we call the anamnestic response or a memory response to the second infection. So measuring antibodies is not a good way to measure long-term immunity, because antibodies are supposed to wane. There are only very few antibodies that persist at a high level throughout our bodies. So, but if you have memory B cells, that's good enough. Next time you get COVID or SARS-CoV-2, your memory B cells can expand. And that is the most important thing to remember. For example, there is a fishing ship that went from Seattle very recently. It's called an American Dynasty or something was the name of the fishing ship. There were 120 people who had a PCR test for COVID and then were allowed to board on this fishing ship. Unfortunately, the PCR test is not 100% reliable. One guy was false negative for PCR. So he actually had the virus. He infected people on the ship who were freely mingling. So when the ship turned around, they came back when they got COVID, and everybody disboarded and they checked again. So who had antibodies? So turns out that out of the 120 people, 103 got infected, including the first guy. 14 people who did not get the infection, and 3 people who did not, out of the 14 people, none of them had antibodies. And then were 3 other people who had antibodies, pre-existing antibodies to SARS-CoV-2, and they also did not get infected. So essentially, the only people who boarded the ship with COVID antibodies did not get infected. Out of the other 117 who boarded without COVID antibodies, 103 got the infection. So the rate of, so if you do have antibodies, it seems like it does protect you. So we and many others, including the biggest push was from the FDA to do a convalescent plasma study based on historical use of convalescent plasma and the hypothesis that patients who recover from COVID have antibodies that survive in their bodies that can be given, separated out in the plasma and given to the sick patients. This is now FDA approved based on the large, I wouldn't call it a phase 3 study, it's a phase 2 study because there is no control group. 4,300 patients got this. They were all hospitalized patients, but there was no difference in 7-day mortality. But if you went back and looked at the plasma they got, and if they had what we call high titer plasma, that means a high titer of IgG antibodies against COVID, those patients seem to have a slightly better mortality, especially if they were less than 80 years old and treated within 72 hours of diagnosis. So basically, plasma helps early on, it looks like, but again, it cannot overcome the severity of age. It cannot overcome the severity of intubated patients, and it can probably help people who are early in the stage of infection. So this has led to a new study that's going on right now where people are trying to give plasma to patients who are coming to the ED right away. But there are many, many problems with giving plasma. Not all antibodies neutralize the virus, as we said before. Titers can vary, and sometimes plasma can harm the patient. So passive antibody therapy is now what's being pursued in a different way. So if you can actually separate the cells that make the neutralizing antibody, you can actually come up with a couple of antibodies that are to the receptor binding domain, but they are 2 different antibodies. And if you give a cocktail of those, you can actually prevent what we call escape of the antigen. The virus is multiplying in the cell. And if you give a single antibody, the virus in the cell, inside the patient, after you've given the antibody, it might actually mutate and the antibody may become effective. So if you give 2, it is very unlikely that the one virus has 2 mutations that can inactivate both of your antibodies. So there is this approach called the cocktail antibody approach. And of course, the most important patient who got this was this guy, who got the cocktail of these 2 antibodies, Regeneron 10933. And so this is the macaque study. When he got it, he was, I think, patient number 8 or something. This is the study. So this is in monkeys. And as you can see, if you got the 150 milligram per kilogram treatment, the lungs looked beautiful. Whereas if you didn't get it, you got consolidation. So what is the death toll? So again, I don't believe that what we are reporting and seeing is the real death toll. This is the morbidity and monthly weekly report, mortality weekly report. And it seems like at least 100,000 more people have died than we know. And this is not all from COVID, obviously. This is from COVID plus other causes related to COVID, or this is the excess mortality in the US in that period. So, and if you look, and we always say that the young people are safe. It's not true. Look at who lost the most. So if you're less than 25 years, the overall mortality in the US in this period was actually lower than what happens every year. So less young people died in the US in this period than usual. And that's probably because there is less homicide, there is less accidents, there is less other things. But if you look at 25 to 44-year-olds, 25% of those patients of people more mortality. And if you look at 75 to 84, it's only 21% more. And if it more than 85% years old, it's 14% more. So actually the biggest excess mortality is for the middle years of life, 25 to 44 years. So ultimately, I would say that we actually don't know how SARS-1, or now retrospectively you can call it SARS-CoV-1, disappeared. but essentially it disappeared as a story of public health, and we might actually still have to go back to public health. And when you talk about public health, we talk about herd immunity. And herd immunity is a very bad idea if you want to get it by actual infection, because you are actually, so just assume this number. We assume that one COVID patient can infect 3 others. So the R0 is 3. And we are even ignoring the other more important number known as the dispersion parameter, or K. But even if you just ignore that, and if an R0 of 3, you need to have at least 230 million people infected in the US, at 23 million people hospitalized, and 2 million people dead before you will get enough herd immunity to get 70% infected. So the more the R0, the more number of people who need to be infected to get herd immunity. So vaccination to get herd immunity is reasonable. Disease to get herd immunity seems highly unreasonable. And this is not the first time we have faced it. Obviously, influenza has been here with us before, and many pandemics and plagues have come to the humanity in the past. So these viruses are actually classified as newly emerging, re-emerging, or deliberately emerging. And there is a lot of myth going around that this virus is deliberately emerging. That is really not true. If you look at that, the coronaviruses are very endemic in many animal species, including bats. And if a virus can go from one species to another, that depends on what we call a fitness valley. So the donor species, in this case, bats or pangolins, whatever you want to call it, probably bats, they basically have viruses that have sufficient mutations so that one mutation can make it jump into the next species, which is us. And when you look at basically the spike protein in multiple coronaviruses, bat, human 1, human 2, etc., there are only very little change between these viruses. So that's why these viruses can jump to us. And this is not the last time it's going to happen. It's going to happen many more times. And there is a lot of reason to study bats, so that again, people going to study bats in Wuhan, that is not because it is they're trying to create an artificial virus. That is because it is important to study bats. Bats carry many viruses, as you all know: rabies, corona, Nipah, parainfluenza, many other paramyxoviruses, etc. And they do that because they have a heightened innate immunity, and in bats, these viruses are rapidly multiplying. There are a lot of hypotheses why that is the case. One of them is called the metabolic stress of flight. It's like bats always have a little fever going on because they have a high metabolic rate, etc. And in us too, the virus is evolving, and that may be one of the reasons the mortality has actually come down in many countries and is surprisingly low in countries like India. So I'm going to finally sum up in the next 1 minute. So as you can see, COVID-19 is especially devastating in older people in terms of mortality, ICU admission, case fatality, etc. Why does that happen? So this is the major difference between a young immune system and an aging immune system. Young immune system has a controlled immune response and basically has a better coordination between the innate immunity and the adaptive immune response. An aging immune system is characterized by what we call inflammation or inflammaging and immunosenescence. Many of the immune cells are undergoing senescence and reduced function and reduced numbers during that time. The only type of immune cell that goes up in old age is NK cells, which is they're part of the innate immunity, and that is actually leading into a bad idea because it actually causes residual inflammation, which leads to what we call inflammaging. So in residual low-level inflammation going up is a characteristic feature of aging. It's just like sarcopenia and many other things that you will hear about later in the series. And that leads to increased infection risk, poor response to vaccines, increased cancer, increased autoimmunity, etc. So finally, I would highlight 2 points. A combination of age-related immune changes that predicts mortality has been developed. It's characterized by low B cell numbers, reduced T cell response to mitogens that kind of like vaccines, CD4, CD8 ratio less than 1, and CME positivity. So this combination of events actually leads to a clear-cut increased mortality and reduced survival in older patients, and characterized by recurrent infection, poor wound healing, autoimmunity, cancer, malabsorption, etc. Can we do anything about it? So there are a lot of experimental approaches like using IL-7 and restoring your thymus, using statins, metformin, mTOR inhibitors. There are drugs that have a property of can reverse it. But before any of them are getting approved or proven, there are other things you can do. Vitamin D is a proven beneficial agent in this setting. Zinc seems to be working well too. Exercise helps. That should be moderate. Strenuous exercise is actually a bad idea because it is immune suppressive, like in marathon runners and triathletes and etc. Stress is a bad idea, as we all know. And vaccination should be followed by checking titers so that you can prove that people have responded. With that, I stop.